Welcome to the today's session from the infection module. We begin with management of bacterial vaginosis. We are going to cover 2-3 infections today. So bacterial vaginosis, it is the commonest cause of abnormal vaginal discharge in women of childbearing age group. Prevalence is variable, 5% to 50%. In college-going students, it is around 5%, and while in adults in Uganda, they have reported is a 50%. In general, around 12% pregnant women in UK and 30% women undergoing termination of pregnancy will have bacterial vaginosis. These rates are not important from examination point of view. Lactobacilli are the dominant bacteria in the healthy vagina. The pH is maintained below 4.5 and there are low levels of other bacteria. This pathophysiology you should understand because there is a role of this lactobacilli in maintaining the normal healthy vagina and its pH. So in bacterial vaginosis, what happens? The pH of the vaginal fluid is elevated above 4.5 and it may reach up to 6. Lactobacilli may be present, but the flora is dominated by many other anaerobic and facultative anaerobic bacteria. So conventional culture techniques identified Gardnerella vaginalis, Parvotella species, Mycoplasma hominis, and Mobilianca species as those are most commonly found. Okay. So generally there is a reduction in the lactobacilli. Lactobacilli may be present, but other anaerobic bacteria are increased. So that is what is the pathophysiology in bacterial vaginosis. Then coming to the clinical features, symptoms, there will be offensive, fishy smelling vaginal discharge, generally not associated with the soreness, itching or irritation. Many women, approximately 50% cases are asymptomatic. Okay. And signs, there will be thin, white, homogeneous discharge coating the walls of the vagina and vestibule. Bacterial vaginosis generally not associated with the signs of inflammation. So bacterial vaginosis, and what are the other key associations? Okay. It is not a sexual transmitted disease, but it is strongly associated with the other STIs and other genital infections. There is increased risk of HIV acquisition. There is a high prevalence of PID in these patients. Common in women undergoing elective termination of pregnancy. There is increased risk of post-termination endometritis and pelvic inflammatory disease in these patients. What are the obstetric and surgical associations? In pregnancy, what it can lead to? In pregnancy, it can lead to late miscarriages, preterm birth, PPROM, postpartum endometritis. Okay, so these are the pregnancy associated conditions with bacterial vaginosis. Then what are the gynecological associations? There is increased risk of vaginal cuff cellulitis and abscess after transvaginal hysterectomy. So after vaginal hysterectomy, you may get vaginal cuff cellulitis and abscess formation. Okay, so clinical impact is unclear in UK. Then diagnosis of bacterial vaginosis. Culture of Gardnerella vaginalis is not diagnostic. It can be present in more than 50% of asymptomatic women. There are two diagnostic approaches. So generally these patients you will get a Gardnerella vaginalis, but culture, if you get culture on the Gardnerella vaginalis, that is not a diagnostic. So what are the diagnostic criteria for this bacterial vaginosis? So one is a Amsel's criteria. Okay. So at least 3 criteria out of 4 criteria should be present. These Amsel's criteria you should remember. There can be thin, white, homogeneous discharge, clue cells on a wet mount, vaginal pH is more than 4.5, and there is a fishy odor on adding KOH. Okay, sorry. You are able to see the slide or no? Is the present slide visible? Yeah. So this clue cell is going to be very important feature. Okay, it's a buzzword, and the vaginal pH. So these two things you remember, because vaginal discharge, there are many causes. But if you see the clue cells and vaginal pH more than 4.5, select this as a answer. Okay, bacterial vaginosis. Then other is a gram staining. Okay. Then there is a Hay-Eason's criteria. If you do the gram staining, normally lactobacilli will be predominant. That is grade 1. In grade 2, you have mixed flora. And in grade 3, that is a bacterial vaginosis, there will be a predominance of the Gardnerella and Mobiliancus. Okay. Then there is a Nugent score depending upon the presence of the lactobacilli, Gardnerella vaginalis, and Mobiliancus. They have scored. Okay. If there is a reduction in the lactobacilli, or if there is an increase in the Gardnerella and mobile uncus, then it is a scored. Okay. And if the score is between 0 to 3, it is normal. If it is 4 to 6, it is intermediate. And if it is more than 7 or equal to 7, that is suggestive of the bacterial vaginosis. So they take into account lactobacilli, Gardnerella vaginalis, and mobile uncus. Decrease in the lactobacilli, increase in the Gardnerella, and increase in the mobile uncus. Lactobacilli is scored from 0 to 4. Gardnerella is scored from 0 to 4. And mobile uncus is scored from 0 to 2. So that is why total score is 10. So lactobacilli is given 4 score, Gardnerella is given 4 score, mobile uncus is. This score is not asked, but what is the score that you should remember? More than or equal to 7 is suggestive of bacterial vaginosis in the Nugent score. Okay. And for Hayes's criteria, it is a gram staining of the vaginal smear. And this is the Amsel's criteria. But here the Amsel's criteria are going to be more important because they are practically useful. These you can use it for the practical purposes, while this is not that practically useful. Okay. Then coming to the management of bacterial vaginosis, general advice. Always remember the general advice, especially when you are talking in the part 3 OSCE stations. So avoid vaginal douching, then avoid shower gels, antiseptic shampoos in the bath water. Who should be treated? The symptomatic women are to be treated. Women undergoing selected gynecological procedures need to be treated, and asymptomatic women may be offered the treatment, and they may choose the treatment if they are offered. Okay. They will report improvement in the discharge if they have taken the treatment. See this treatment very carefully, because when it is asked in the EMQs, you may get confused. Okay. What is the first line drug for the treatment of bacterial vaginosis? It is metronidazole 400 milligram 2 times a day for 5 to 7 days. Now, each and everything you should remember: metronidazole 400 BD for 5 to 7 days. Okay. So for this only, they can make 3 or 4 options: metronidazole 400 milligram TDS for 5 to 7 days, 400 milligram BD for 5 days, 400 milligram BD for 7 days, and this is the 5 to 7 days 400 BD. So remember, this metronidazole 400 BD for 5 to 7 days is the first line treatment. And alternative is metronidazole 2 gram single dose. This is or okay. And when you will later on learn about Trichomonas vaginalis, again the treatment is same, but the first is a metronidazole single dose 2 gram, and then the alternative 400 milligram BD, but that is for 7 days. Okay. Then next is here intravaginal metronidazole 0.75% once daily for 5 days. Then intravaginal clindamycin 2% daily for 7 days. So if you use clindamycin, so we have oral treatment and we have topical treatment. In the oral, we have metronidazole long treatment for 5 to 7 days. Metronidazole, second will be metronidazole oral single dose. Okay. Then in the topical, metronidazole is there, but the 0.75% topical for 5 days only. If you use clindamycin 2%, then it is for 7 days. Okay. And this is the first line option. While alternative is a tinidazole 2 gram single dose, clindamycin 300 BD for 7 days, and follow a test of cure is not required. Okay. Here the test of cure is not required if there is a resolution of the symptoms. Okay. Then certain things you should remember from the treatment point of view, that is intravaginal or topical treatment will reduce the effect of the condom. So there is a risk of unintended pregnancy. Fluconazole and multiple doses of azoles, they can lead to the drug interactions, increased risk of QT prolongation and hypokalemia. And if there is a poor response to the treatment, consider that you may be dealing with other diagnosis or non-candida albicans can be there. Okay. Then what is the caution while treating the bacterial vaginosis? This can also be asked and you need to remember, because they may give a scenario which is very, very specific. Okay. Like metronidazole. Along with metronidazole, alcohol is to be avoided because it causes disulfiram-like reaction. Alcohol not recommended with intravaginal gel also. So even if you are using intravaginal metronidazole 0.75%, and what is the duration of metronidazole? It is 5 days only, while clindamycin intravaginal is for 7 days. Okay, so even you cannot use alcohol along with the topical intravaginal gel. Okay, when you use clindamycin, it will weaken the condoms. So rare risk of pseudomembranous colitis is also there with clindamycin. Patient may be allergic to the metronidazole, but it is rare. In that particular case, use 2% clindamycin cream if the patient is allergic. And pregnancy and breastfeeding, metronidazole is safe in the first trimester. There is no teratogenic risk. So these are the things which you should remember. In the scenario, they may give that the patient is alcoholic. Then you need to take into account that you will not be able to give the metronidazole. Okay, so that finishes the topic of bacterial vaginosis. Thank you.
Okay, thank you.
Yeah, next topic is we begin with next topic, management of vulvovaginal candidiasis. This is British Association of Sexual Health and HIV National Guideline 2019. This guideline, there are EMQs which are asked in the past from this particular guideline. This is a TOG article, but very important from the examination point of view. Okay. So for recurrent vulvovaginal candidiasis, what is the test of choice? Microscopy is the first line test for acute vulvovaginal candidiasis. Okay. While culture is not the first, but the microscopy is first in acute vulvovaginal candidiasis. Culture not for acute vulvovaginal candidiasis, but it is indicated in recurrent vulvovaginal candidiasis for identification of the species and sensitivity. Okay, so oral azoles, they are to be avoided in pregnancy and breastfeeding. Ketoconazole is not recommended, and there are non-azole therapies. They are reserved for azole resistance or non-albicans candidas. So in the examination, they may ask you pregnancy related, or the patient is breastfeeding, or there may be resistance, or there may be some different species which is apart from Candida albicans. So you need to select the drug appropriately. That is why this topic is going to be very, very important. Okay, now let's talk about acute vulvovaginal candidiasis. So it is either the first episode or isolated episode of vulvovaginal candidiasis. Generally, the patient will have symptomatic vulvovaginitis, and you will get the candida detected on microscopy. Culture may or may not be positive. Okay. Recurrent vulvovaginal candidiasis, when we talk about recurrent vulvovaginal candidiasis, there are criteria. At least 4 episodes should be there in 12 months, out of which at least 2 episodes should be microbiologically confirmed. And when patient is symptomatic, at least one should be culture. Okay, at least one culture should be positive. Okay, then clinically we can divide these patients into two. That those patients who are responding well, and in between the episodes they are asymptomatic. While in a second group, generally there is a partial response to the drug, and patient will have persistent symptoms. Okay. Now coming to the etiology, it is a fungal infection caused by the Candida species, and Candida are eukaryotic yeast capable of pseudohyphae and biofilm formation. But there are some non-Candida species also. So in 80 to 89% of cases, it is Candida albicans, while other non-albicans Candida or other yeast such as Candida glabrata, tropicalis, crucei, parasilosis, Saccharomyces, etc. These are non-albicans Candida. Okay, so non-albicans species, in these patients there is a azole resistance and recurrent disease. Okay, so when there is a recurrent disease, we might have to think about these non-albicans Candida. Okay, coming to the vulvovaginal candidiasis risk factors and pathogenesis. Generally, there is a persistence of Candida albicans in between the episodes. So when we say that it is a persistent, in that particular case, there will be culture will be negative, but there will be PCR positive. Okay, so PCR will be positive in these patients. Poorly, there may be associated with poor control of diabetes mellitus, immunosuppression, high estrogen levels such as pregnancy, HRT, or the patient may be on combined oral contraceptive pills, or there can be use of antibiotics in last 3 months, or there can be local factors such as new sexual partner or spermicides. Then treatment factors such as non-compliance or antifungal resistance, and patient may have iron deficiency anemia. Or there can be genetic susceptibility. such as mannose binding lectin, MBL deficiency. Okay, so this MBL deficiency increases the risk of acute and recurrent vulvovaginal candidiasis. Okay, so this MBL deficiency also you should remember in vulvovaginal candidiasis. So coming to the clinical features, there will be vulval itch, non-offensive vaginal discharge, soreness, burning, superficial dyspareunia, and clinical cyclical symptoms will be there. While in signs, there will be erythema, fissuring, swelling, curdy, non-offensive discharge. It may be thin or absent also, and there will be satellite lesions and excoriations. Okay, so in candidal vulvovaginitis, remember this satellite lesions also. Okay, so if you get the satellite lesions, curdy discharge, and these symptoms, think of vulvovaginal candidiasis. Differential diagnosis such as eczema, lichen sclerosis, lichen planus, bacterial vaginosis, then trichomonas vaginalis, aerobic vaginitis, which is purulent non-offensive discharge, then cytolytic vaginitis. Here microscopy will and culture will be negative. Vulvodynia and vestibulodynia, VIN and other vulval cancer can be in the differential diagnosis. Now, in this slide, we can see the difference between the bacterial vaginosis, trichomonas vaginalis, and what we have discussed just now is a vulvovaginal candidiasis. So these three are the differential diagnosis for each other. We have just discussed about the vulvovaginal candidiasis, symptoms and signs. What happens in bacterial vaginosis and what happens in trichomonas vaginalis. Okay, so in bacterial vaginosis, we have already mentioned that there is an imbalance of the vaginal flora and there is increase in the pH level from 4.5 to 6. And there are fewer lactobacilli and increase in the anaerobic bacteria. And risk factors are the smoking, dowsing, black ethnicity, new sexual partner, current sexually transmitted infections such as herpes, and receptive cunnilingus. These are the risk factors for bacterial vaginosis. Around 50% patient may be asymptomatic, and other symptoms for the presentation will include offensive fishy discharge, which is typically thin and white gray in cases of bacterial vaginosis. Bacterial vaginosis. Okay, pH testing of the litmus paper, if available, we can do that. Then microscopy and other diagnostic criteria to aid the diagnosis, such as Amsel's or Hazen's criteria. This also we have discussed along with the bacterial vaginosis. Then management, we have seen metronidazole 400 BD for 5 to 7 days. Metronidazole 2 gram is an alternative. The intravaginal gel also we have seen. Intravaginal clindamycin also we have seen. Then alternative is a tinidazole. This is pertaining to the bacterial vaginosis. Okay, and we need to discuss about the general vulval hygiene also. Okay, now for Trichomonas vaginalis, it is an STI, that is sexually transmitted infection, which is caused by the flagellated protozoa, that is Trichomonas vaginalis. Generally, it is seen in more elder patients, that is more than 25 years, non-white ethnicity, concurrent associated with the chlamydia trachomatis or Neisseria gonorrhoeae, and people living with HIV. There will be vaginal discharge, which is malodorous in nature, vulvovaginal itch, dysuria, vulvovaginitis, vulval ulceration, and low abdominal pain. Up to 50% may be asymptomatic. Then you need to take the vaginal swab, which are taken from the posterior fornix. When then it is tested using, depending upon availability, by wet preparation microscopy. NAAT is the preferred test. You have the point of care test NAAT also, and then the culture for Trichomonas vaginalis. Okay, so first choice will be the triple NAAT if available, but if not, then send sample separately for NAAT, Trichomonas vaginalis culture, and TB point of care test. Okay, depending upon the availability. Okay, and the treatment of choice is a 2 gram metronidazole stat, while metronidazole 400 to BD for 5 to 7 days is an alternative, and other is a tinidazole 2 gram stat. So here there is a difference between the treatment of bacterial vaginosis and Trichomonas vaginalis. So first treatment here will be 5 to 7 days of metronidazole, and second will be metronidazole 2 gram. While in Trichomonas vaginalis, it is a first 2 gram oral stat, and alternative will be 400 to 500 milligram BD for 5 to 7 days. Okay. and tinidazole is an alternative treatment. Okay. So that is what is the difference between the bacterial vaginosis and Trichomonas vaginalis, and these two are the differential diagnosis for vulvovaginal candidiasis. Now we come back to the vulvovaginal candidiasis investigation. So first line is a high vaginal swab for gram stain and wet mount. What you will see, blastophores, and you may get pseudohyphae also plus neutrophil. That will tell us about the candida infection. Okay, so you'll have blastospores plus pseudohyphae plus neutrophil. If you get only blastopores and the neutrophils, then you may consider the candida glabrata. Presence of neutrophil will indicate inflammation, and if there is a candida without neutrophil, that means just a colonization, that there is no inflammation, so it is just a colonization by the candida, so there is no neutrophils. Okay, so culture is not recommended in acute vulvovaginal candidiasis, while it is indicated in recurrent vulvovaginal candidiasis, and it is done on the fungal culture on Sabarod's medium. Okay, so up to 20% of women colonized with candida. These patients do not require treatment if they are asymptomatic. Okay, and most important thing is whenever you advise start the treatment, it is the general management advice is going to be very, very important. So when you have EMQ option, so any option with other general advice along with the pharmacological correct option, that you need to select. Okay, so general advice will be avoid local irritants such as perfume, soap, wipes. You can use the emollients for the soap substitute or moisturizer or barrier. And sex is not contraindicated because vulvovaginal candidiasis is not a STI, but it can be avoided until symptoms settle, especially if there is a fissuring. Okay, then recurrent vulvovaginal candidiasis, additional advice which is required is always review the hygiene practices. Hair washing in the bath water, excessive cleansing is not advisable. Consider weak association with the non-breathable or tight clothing. Daily panty liners, vaginal douching, and vulval emollients are helpful. Okay, so these are the things which we need to advise first. Okay, now coming to the further investigations, is there any additional investigations apart from microscopy and culture? So there are certain additional investigations which you need to do. For acute vulvovaginitis, no routine further investigations are required. But if there is a recurrent vulvovaginal candidiasis, you have to exclude the diabetes mellitus. You will be doing the urine analysis, random glucose, HbA1c, especially in a prepubertal and postmenopausal women. You will also check the iron deficiency, do the full blood count plus ferritin levels, and consider MBL deficiency if suggestive history of recurrent infections and autoimmune disease. Okay, then vaginal pH testing. If it is a pH is less than 4.5, it will support vulvovaginal candidiasis. However, if it is increased, then consider bacterial vaginosis or trichomonas infection. Secretion should be collected from the lateral sides of the vaginal wall using a swab. A tiny amount of discharge is put on the litmus paper. So when you do the litmus paper, they have mentioned the lateral side of the vaginal wall. Okay, for litmus test. Then coming to the treatment of acute and recurrent vulvovaginal candidiasis. This is going to be very important from examination point of view. Please concentrate. There is a lot of confusion in the doses and the duration of treatment. Okay. And they ask either non-pregnant status or pregnant status. So the treatment are different for pregnant women as well as non-pregnant women. So if it is acute vulvovaginal candidiasis, the fluconazole is a treatment of drug of choice, 150 milligram single dose treatment. And if it is a topical, you use clotrimazole pastry 500 milligram per vagina single dose. So acute vulvovaginitis, you have a single dose treatment. Both oral as well as topical is available. Okay, oral you use fluconazole 50 milligram single dose. Topical you use clotrimazole 500 milligram per vaginal single dose. Okay, this is for uh, Candida albicans. If you have a non-Candida albicans species, then it is the nystatin pessary, 1 lakh units per vagina and to be treated for 12 to 14 nights. Okay, so here the duration is prolonged. So please remember what you are treating, whether we are dealing with acute vulvovaginitis or recurrent vulvovaginitis, whether what is the oral treatment is given or the topical treatment is preferred, and what is the agent, whether you are dealing with the albicans or non-candida albicans. Sometimes they may give in the scenario the patient is not comfortable to use the drug vaginally. That means the oral treatment is required. Then you will select the appropriate option. Okay. Then coming to the recurrent vulvovaginal candidiasis. For recurrent vulvovaginal candidiasis, it is a long duration treatment. Almost 6 months you need to treat the patient. You have the induction and the maintenance of this particular therapy. So induction of therapy with oral agent, you have fluconazole 150 milligram, 3 doses, followed by fluconazole 150 milligram orally per week for 6 months. Okay. So for recurrent vulvovaginitis, you can use 150 milligram every 72 hours for 3 doses, followed by fluconazole 150 milligram OD for 6 months. Next is a clotrimazole pessary 500 milligram vaginally for 7 to 14 days according to the response. That is the induction dose for recurrent vulvovaginal. So here it is a 2 weeks of induction with clotrimazole pessary 500 milligram 7 to 14 days, followed by clotrimazole pessary 500 milligram per week for 6 months. So you will give induction treatment for 2 weeks. It is 7 to 14 days. Remember, it is 7 to 14 days. Sometimes they give option 10 to 14 days, 7 days, 7 to 14 days. So select option as a 7 to 14 days. Okay. And if it is a non-albicans species, then induction is with nystatin pessaries for 2 weeks. Okay, 1 lakh units for 2 weeks per for 2 weeks per month for 6 months. It is 2 weeks per month for 6 months. You will give nystatin. Okay, so here you will give daily for 2 weeks and then weekly for 6 months. Here you will give 2 weeks per month for 6 months. Okay, for non-candida albicans. Now let us see about pregnancy. In pregnancy, there is increased asymptomatic candida colonization, almost 30 to 40% cases. It is just a colonization. But if it is a symptomatic vulvovaginal candidiasis, that can also happen. But what is the safety of these levels? Oral azoles, if oral azoles in high doses and prolonged use more than 400 to 1200 milligram per day are associated with the skeletal malformation. Okay, but single dose 150 milligram stat, there is no increase in the congenital risk, but still avoid routinely. Okay, so as far as azoles are concerned, single dose relatively safe, but still avoid. Okay, and higher doses are associated with skeletal malformation. So treatment of choice is a topical azole. So BASH recommends 7-day clotrimazole pessaries. There is a 90% cure. Okay. So this is the treatment for vulvovaginal candidiasis in pregnancy. So they have asked this. Okay. So acute vulvovaginal candidiasis, here it is a 7-day treatment. There we have seen a single dose treatment, either oral or vaginal. Okay, in non-pregnant state. But here in acute vulvovaginal candidiasis, clotrimazole pessary 500 milligram, one in a night for 7 days. So you have to treat acute vulvovaginitis in for 7 days. While recurrent vulvovaginitis, you have induction with clotrimazole for 10 to 14 nights. You have to give daily and maintain 500 milligram vaginally once per week. Duration they have not specified here. Okay. Now here you just remember, when you are giving treating recurrent vulvovaginal candidiasis, you have to treat for 10 to 14 nights according to response. Okay. If you go here, here it is written 7 to 14 days, and here it is 10 to 14 nights. So this particular difference you remember, because even these minor differences are there in the options. So if you are treating non-pregnant status, then it is 1 to 2 week. While if you are treating in pregnancy, the same dose, but it is for 10 to 14 nights. These are very, very minor differences, but you need to concentrate because in the EMQ, both options can be there. So if it is a pregnant state, you select 10 to 14 nights. Okay. Followed by 500 milligram per week. Okay. Now, important points about vulvovaginal candidiasis. Topically treatment or intravaginal treatment may reduce condom effectiveness and may lead to increased chances of unintended pregnancy. Fluconazole and oral azoles can have drug interactions. There is a risk of QT prolongation and hypokalemia. and there is a poor response to the treatment, consider non-albicans candida and reassess for alternative diagnosis. Okay, so that finishes the topic of candida albicans. I hope the topic is clear to you. Thank you.
Thank you, sir.
Now, yeah.
There, how
Uh,
many more topics are there?
See, this is hardly 5 minutes talk, Trichomonas vaginalis. After
Okay.
that, there are question answers. And if you are okay, then I can cover mycoplasma also. Otherwise, we'll finish with the Trichomonas vaginalis and a question answer. Is that okay?
Yes, because I think it will be okay.
Yeah, yeah, yeah. 10 minutes more, I think. Okay.
Okay, okay, sir.
So welcome all to the infection module. We begin with Trichomonas vaginalis. So positive organism is a Trichomonas vaginalis, which is a flagellated protozoa. Sites of infection are the vagina, urethra, paraurethral glands. Isolated affection of the urethra is seen in less than 5% of cases. Most of the time it is the urethra and the vagina which is affected. Transmission is sexual intercourse, almost exclusively seen by the sexual intercourse. Okay. Then clinical features are in females and males. In females, generally 10 to 50% cases are asymptomatic. Most common presentation is a vaginal discharge, vulval itching, dysuria, offensive odor, but these are not very specific for Trichomonas vaginalis. Occasionally, the presenting complaint is of low abdominal discomfort or vulval ulcerations. In males, around 15 to 50% patients may be asymptomatic and usually present as a sexual partners of infected women. So during tracing of the partners, they may be found. But the commonest presentation in symptomatic male is a urethral discharge and dysuria. Okay. So while in females, it is a vaginal discharge. Okay. Because isolated urethral affection is not common in females. In less than 5% you get here. But in males, if it is a symptomatic, they will present as a urethral discharge and or dysuria. Other symptoms will include urethral irritation and urinary frequency. Patient may complain of copious purulent urethral discharge or complications such as prostatitis. Okay. Then signs, there will be vaginal discharge in 70% cases in females. Depending upon consistency, it may be thin and scanty, and sometimes it may be profuse and thick also. The classical frothy yellow discharge is seen in 10 to 30% women. So if you get a frothy yellow discharge, think of Trichomonas vaginalis. Okay. Then there may be vulvitis, vaginitis, and 2% patients will have strawberry cervix. Okay. Appearance to the naked eye, higher rates are seen in colposcopic examination. So this is also a buzzword pointing towards Trichomonas vaginalis. So though it is seen in 2% of patients, but if you see this buzzword in the examination, strawberry cervix, select the Trichomonas vaginalis. 5 to 15% women will not have any abnormalities on the examination. While in males, you will get the urethral discharge in 20 to 60% of male, usually small or moderate amounts only, and they may have dysuria also. A few patients may not have any signs, and rarely there can be balanoposthitis. Okay. Now, investigations. Swab is taken from the posterior fornix. Remember, they may give you various options. So, vulvovaginal swab from the posterior fornix is the choice for this Trichomonas vaginalis. Self-administered vulvovaginal swab will give equivalent results. Then urine has been used for evaluation with some nucleic acid amplification test. In males, it is a urethral culture or culture of first void urine will diagnose almost 60 to 80% of cases. Okay. Now, for diagnosis, for microscopy, it is the weight mount preparation, vaginal discharge plus normal saline is used. Examine within 10 minutes. View first at 100x, then see at 400x, and you will see motile trichomonads with flagella. Sensitivity is low, 45 to 60%, and highest in women with the vaginal discharge. Okay. The other option is a culture, more sensitive than the microscopy. Previously, culture was gold standard. Now it is superseded by the molecular test such as NAAT. Okay. So the gold standard test is now NAAT. Okay. And it has got the highest sensitivity. So if they ask you about Trichomonas vaginalis, the gold standard test will be the NAAT. Okay. Nucleic acid amplification test. Okay. Now coming to the management. First, we'll talk about the general advice. Treat all sexual partners simultaneously. Avoid intercourse until treatment is completed, minimum for 1 week. Look at the treatment here. In Trichomonas vaginalis, again the metronidazole is a drug of choice, but it is a single dose which is used. Okay, 2 gram stat is the preferred, while other alternative will be 400 to 500 milligram for 5 to 7 days. While in bacterial vaginosis, this was first metronidazole 400 milligram BD for 5 to 7 days. That was the treatment of choice. And alternatives will be tinidazole 2 gram stat, similar efficacy but more expensive. And in HIV positive women, metronidazole 500 BD is to be treated for 7 days, more effective than 2 gram single dose. So if you have a non-HIV patient, go for single dose for Trichomonas vaginalis. If you have HIV positive, then treat it for 1 week. Okay, that is more effective than the 2 gram stat dose. Okay. Now coming to the breastfeeding and the pregnancy consideration for Trichomonas vaginalis. Metronidazole is safe in all trimester, can be used during breastfeeding also. If single high dose, consider stopping the breastfeeding for 12 to 24 hours. Okay. Tinidazole is a category C drug, contraindicated in first trimester, safety in pregnancy not well established. Avoid alcohol during treatment and at least for 48 hours for metronidazole, and 72 hours after the tinidazole, the alcohol is to be avoided because it causes disulfiram-like reaction. If there is a treatment failure, then think about the compliance, inadequate treatment, reinfection, or the drug resistance. Check for compliance and partner treatment and sexual re-exposure. Okay. Now follow up for Trichomonas vaginalis. Test of cure not routinely required. Recommended only if symptoms persist or symptoms recur after treatment. Okay. So test of cure in Trichomonas vaginalis is routinely not required. But if there are symptoms or if they recur, then we have to do the test of cure. Then contact tracing. Current sexual partner is to be treated, and all partners within 4 weeks are to be tested and treated. Screen for full STI panel and treat for Trichomonas vaginalis regardless of the test results. Okay, so all partners are to be treated. Okay, current sexual partner as well as all partners within 4 weeks. Okay, so that finishes the topic of Trichomonas vaginalis. Thank you. Okay.